You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
First attempt at streaming live, it looks abysmal from what I can see, so we'll see how this turns out, and we'll pay attention to the chat. It looks like there is a 10-second delay, maybe. But either way, if you have a question, you can put it in on the Riverside chat if you had the link to that, which I just posted on Instagram. But I'm going to try to make these a little more interactive if we have viewer questions. And then we've changed the format of the week in review. It's fun to talk all nerdy and talk clinical cases and stuff like that. But I think like 5 people listen, and one of those people is Tyler Limburner. So if you're listening and you have a question on the live chat, chime in. We appreciate you listening. But we're going to change the format up a little bit. First things first, it's kind of anything exciting going on with you guys. Maybe don't get too personal. I mean, we don't need to know about like, you know, an impressive bowel movement or being evicted. Well, that's off in the future a bit. Have you guys found any place to live?
No, waiting on my tax return.
I'm waiting on Alex to get his tax return.
Pre-approval, all that jazz.
Yeah.
So you're still trying to buy a house?
Yeah.
And I'm trying to rent from the guy who's trying to buy a house.
Oh, so you're going to be, oh, look, you already have an investment property.
Yeah.
Okay.
Our third option is moving to England.
Yep.
Okay.
Finding somebody else.
Oh, with Evan?
No, Evan.
No,
Oh,
Evan.
your third option is
Yeah.
moving. I thought you
Yeah.
said your third option is moving to England. I was like, that's a, okay.
2025's been off to a hot
Buy a
start.
house, rent one, or move to
Yeah,
England.
There's a lot going on in
Yeah,
2025.
remove from a house, buy a house. Not sure when he's going to buy a house. See,
Not
other
sure if-
roommate,
Not sure if we're getting approved for a house.
other person's moving to England. Yeah, so it's been sweet.
That's fun.
I had the stomach bug earlier this week.
Yeah, I
That
got
absolutely torched me. That's
got a
pretty
little-
exciting.
cold going on.
Everybody's dropping like flies. I was sick last week, but we have kids, so we have a better.
Y'all bring the stuff here.
Hey, there was no stomach bug coming from us.
I
That
don't know,
was
whatever crap he had.
Yeah. That was church group right there for you.
It was.
Anything else? So I got hot and heavy on the. I posted all of it, and I followed it for the first 8 weeks to a T. But trained for the Mount Cheehaw 50K, which is Saturday. Also, it was snowing and like 19 degrees this morning, so I hope that changed a little bit before Saturday.
Yeah.
But my motivation kind of tipped off around week 9, mainly just I kind of, well, no, not kind of, I don't like running 26 miles on a Saturday. So I didn't follow the plan to a T after 8 weeks. What was funny was we went to dinner with the Toshes. So if you're from Birmingham, you know, Dave and Mary Jo Tosh are basically the people that are responsible for growing the trail running scene in Birmingham. They hold the Southeastern Trail Series, Blood Rock 100, the Lake Martin 100, now the Southern States 100 and 200. And we were at dinner with them, and Travis Grappo, who owns Oak House, shout out Oak House, came up and we were talking about that. He goes, "Oh yeah. You're like me. You're too ADHD. You can only do a 6 to 8 week block training, like lead up. There's no way you can do a like 12 to 14 week." He goes, "I've had the same thing happen over and over." I was like, "Yeah, maybe that's a good point." So, and then I kind of decided around that 9 week mark that I didn't even want to do the race. I mean, I was signed up from before I did the 14 week training block, but then Sloan was kind of jabbing at me a little bit, and I decided I might as well do it. So yeah, Saturday I'll be doing that. And the goal is sub 5 hours. I think the goal is now just I don't know, race myself, not other people, because then I'll blow up because it looks like some fast people have signed up. So we'll see. But on the next week interview in 2 weeks, I'll give an update on that race and see how it went. Nothing else really going on.
I got, I guess from my end, I got my triathlon season, I guess, finally is going to start.
When's that starting?
Hopefully.
Let's see. Hopefully, yeah. So I got a bike fit yesterday for my
how'd that
tri
go?
bike. It was sweet.
Oh, yeah.
Yeah.
Shout out Bike Link and Hoover.
Yeah, that was
Joe is the man.
Yeah.
He looked at me, and I got on there, and he started asking me like everything that was like painful on this bike, which I basically bought it from a friend, and I just like, this thing will do, and just like hopped on and started riding, and it feels abysmal when I rode it. It's fast, but it feels abysmal. So I did like a sprint try last summer, still didn't like get it fit. So it's been like, I guess, a year since I've had the bike or close to
probably.
it.
And even though it felt abysmal to Seth, he was still crushing me the one and only time I rode with you, which I was on a road bike and you're on the tri bike. So yeah, there's that.
But yeah, he got on there, and I thought the bike it kind of like helped me a little bit, I guess, learn a little bit about the actual positioning of the tri bike, because the bike itself is a little big for me. Like I'm like 5'8", so like a good bike fit for me for a tri bike should be between like 52 and 52 centimeters for like bike frame. This is like a 56, so I'm like right on the cusp of it being like a little too big. So hearing that, I had the seat kind of lowered as far down as I could. Like the seat post itself. And he's like, yeah, you're actually pretty cramped on this thing. And I was like, I'm actually cramped on this. I was like, I feel like it's a little big for me, so I don't feel like I can like toe off as well, like I guess in the bottom of my pedal stroke.
Yeah.
And he's like, no, he's like, my hips were like pretty uncomfortable on that thing. So he actually raised my seat and moved me forward. And once he did that, I felt like a whole lot more like open.
Which makes sense for a tri bike because then you're pushing
back.
back.
Yeah, because he's like, the whole goal of this thing is not to be comfortable. It's to
become less fertile as your basically pudendum gets crushed.
Well, he was just like, he goes, it's to make the run suck less. So, but anyways, we moved everything around a little bit, like moved my seat up, moved my seat forward, and went out back, and like, he's like, I want you to actually put this thing in like big gears. He goes, right now you're not cranking down on it. And he goes, that bike can chew up some ground, because he's like, you have big cranks on there. And it felt like incredible. I was like,
That's cool.
I could push some big power for a long time.
So when's your first race?
So I've got to do duathlon with the Vulcan Tri Club March 1st. So that's next weekend.
Yeah.
Yeah. So it's nice
Memorial
time
Lions
for a
weekend.
stomach bug.
So wait, what in the duathlon
It's a mile run. It'll be a 17.3 mile bike and then a mile run. And then that's all at Oak Mountain. So the bike will be hilly.
Yeah.
So there's no rhythm at Oak Mountain. If you ever come to Oak Mountain, you're like, hey, I want to like get into a groove. Don't. It's fantastic for strength, but it's not like a
Beautiful.
yeah. And then they've got a practice triathlon in April 19th with the club that I'll probably do. There's supposed to be like a sprint tri option, and I think there's supposed to be a longer option if you want to do your longer races, but that is 3 weeks out from my 70.3. So I'm just going to do the sprint tri, just like a gear up.
Where's that at?
Which one?
That sprint.
The sprint. It's going to be at Oak Mountain as well. So it'll be in the lake, and then it'll probably be, if I had to take a guess, out to like Longer Lake area and back from the beach. And then
And you landed on which half Ironman?
I'm going to do 70.3
getting stuff
Gulf
canceled
Coast.
and all that.
Yeah, so the reason I say like earlier that I was like, my season's going to finally begin, last year I actually built
He's been
up.
training for 15 years at this point with
Pretty
no
much.
race.
But I built up last year. I did a sprint in Tennessee in, I think it was June. And then I had 2 other races set up that we were going to do in July. Me and you were going to do one up at Gunnersville.
Buster Burton and Emerald Lake.
You were going to do that half Ironman before that. You were going to do it in the late spring of 24.
I was going to do Chattanooga. Yeah, so there was a there was a lot of like having to shift. Last year was like my first like real year being like in practice, like trying to figure out timing of different things. We went to a couple like seminars like early in the year where we like traveled out of town. I was like, I just can't go like 3 weekends in a row and then go out of town again for a half Ironman.
CCSP thing too.
Yeah.
CCSP. We were supposed to do Mountain Lakes in Gunnersville. Me and Beau were.
Not
and,
Emerald Lakes, Mountain Lakes.
And then you were out of town like 6 weeks in a row, and you're like, I can't do another weekend out of town. I got COVID the week of Buster Britton in August, and then September came around, and I was like, well, at least I'm still signed up for my half Ironman in Augusta. And as I did that, Hurricane Helene decided to make an appearance, and basically just like smoked all of Augusta, which I actually packed. My parents drove down. They picked me up, and we were at my house, and I just went back inside to like go to the bathroom before we like hopped on the road because we had like 4 hours to Augusta. And as I was in there, I came out. My mom goes, "Hey, did you get the email? They just canceled the race." So like I was like seconds away from being on the road heading there.
At least you didn't go.
Yeah, at least I didn't go. So yeah, then didn't get a refund, but we got to change whatever race we wanted to move it around to. So I chose Gulf Coast. So yeah, it should be interesting. It's an ocean swim, which that's kind of dicey. It's like me, sharks, and jellyfish. And then, which I guess I've never swam in the ocean, so I really don't know how far down you can see in like pretty clear salt water.
Yeah, I don't know how far they'll have you
Depends
out.
the further you go out.
Yeah.
I mean.
Yeah, but I mean, you have
harder it
sandbars for a while.
is. Yeah. I don't think I'd want to see.
And then Yeah, it should be a flat bike, flat run. Yeah. It's just going to be pretty warm. There's no shade.
And what's the date on that again?
May 10th.
All right. So we got a lot of stuff. I might do Xterra again. I'll train for it. There's a lot of stuff going on that weekend, and I still don't know how much. I mean, we're going to be involved, but I might be doing it a lot. Mm-hmm. So then I don't know. I'd like to do it again for sure. The big thing is I told myself after this race, after the 50K, that I was going to get a membership at the Y and swim while it was still cold. It would be very hard for me to get to the Y early enough and still get here and do stuff. So I don't know.
They open at 5.
Yeah, I'm here at 6 a.m. on early days getting work done. And then the thought of getting back in that lake like 3 times a week and swimming.
With the E. coli.
That doesn't bother me.
It ain't hot.
It's this thought of driving 30 minutes out to Oak Mountain, swimming in the lake.
Yep.
Then I feel like I want to do some sort of small break, like run or bike with it. And then there's 2 hours. And then, I mean, it's time. So
it takes time.
I'm going to train, but maybe not as much as I did last year.
If you swam any, you would swim more than you did last year.
No, I swam quite a bit leading up to it. But I only signed up 3 weeks before.
Right.
So I swam a lot in 3 weeks.
Right.
So if I got 3 months ahead of it, I started, March, April, May, 2.5.
You basically trained to fatigue and then said, I'm golden. Whoa. Let's get out there and survive.
Yeah. So that's kind of the happenings in here. Like events, you've hit how many Tuesday night runs now?
Oh, man, since the first week. So
first week of January, like
6.
Yeah.
So we've been doing Tuesday night runs. Track Shack and us have partnered together to do runs at Veterans Park. A 3 and a 6 mile option.
3 and 5.
3 and 5 mile option every time. We're brainstorming on how to create a summer series with some giveaways and things like that will be based on attendance. So if you're listening, start showing up so you can put your name in the hat for maybe some stuff at a run or at the end of the year. We're still working on that, so I don't want to announce too much. What else? We'll be at a couple races, working some stuff. So we got the Wine 10K the first weekend of March, or that Saturday, March 1st, I think, right? Rump Shaker, which is March 22nd.
22nd. Yeah.
Saturday. Where's that at?
It is downtown Regions Park.
Yeah.
It starts at Regions Field and finishes there.
So we'll be doing our normal song and dance, stretching, soft tissue recovery, healing, the crippled. Don't show up in a wheelchair and expect miracles. That's not going to happen. I think that's it for events. The Barn Burner, way off in June. Yeah, 10K and half marathon. So it's always been a 5 and 11 mile, which was odd. And I think it'll be easier to market with those distances, but also, it just should be better races because it's easier to train for something that, you're already kind of maybe in the mix for. I think that's it. Anything else event-wise?
I don't think so.
Seminar coming up in Nashville, first week in April. Running retreat, same weekend. So Jonathan Croy, what's this company called? Finish Line. He's doing a 3-day running retreat. Yeah. Friday, Saturday, Sunday.
Sunday.
Yeah.
Midday.
So Alex is doing a talk
Friday night, and then leading the hike Sunday morning.
And then they also have Corey Waltering, which if you don't know who that is, I don't know if he runs for North Face anymore. He might. Ultra endurance athlete that ran for North Face. He was on the Eco Challenge that was last televised on Amazon. He's been on a couple other. He was on another endurance show that we watched. I can't remember what it was. He's a cool guy. Pretty funny. So he's the keynote speaker one day, and then he got Trey from Zombie Trail Races, Terry Morgan from Cadence Running Coaching. Who else? Yeah,
one more speaker.
Yeah. But it'll be good. It's a whole weekend full of running and education. Fun stuff. And if you know Jonathan, it's going to be a good event. So, yeah, I think that's it. So let's move over to, before we off events and happening, this isn't personal to us or the farm, but what in the is going on in track and field?
Craziness. If anybody's been following our social media posts on Thursdays, these guys.
So you got one coming out today, I'm assuming, right?
Yes, but it won't be actually track related. I forgot I made the video, but I haven't posted
it.
Yeah. So in the last 2 weeks or so, give or take, it's there have been, I think, 6 world records broken on the men's side at least. There was like a race walk event in there that I don't know what it was, but I saw that it was of the 6.
You don't keep up with that?
No. It's impressive that you can stick your iliac crest in your armpit, and walk with 2 feet on the ground. But
supposedly.
Yeah, supposedly. I did see some guy walked 5:24 for a mile recently, and that broke a record by like 10 seconds or
There's
something.
no way 2 feet are on the ground.
Right.
No way.
I don't know.
Your legs
But-
be 10 feet long. There's that's not happening.
Yeah. So starting, I guess, shortest to longest, you had the men's mile. This is indoor season, so there'll be different records for the indoor and outdoor track seasons. But men's record in the indoor mile was originally broken at the Millrose Games by American Yared Nuguse. Ran 3:46.6 amongst a huge crowd of other countries' records, and the guy who got second was an American, also would have broken the world record. So it was just a fast race overall. Really cool because the same day, American Grant Fisher broke the American record in the men's 3K, running 7:22, and also another race where you had fast competition. So him and Cole Hawker went to the line. Cole Hawker also broke the previous record, but it was, obviously Fisher leaned him at the line. However, 5 days later, after Nuguse broke the indoor mile record, Jakob Ingebrigtsen soloed a 3:45.1 indoor mile. Now he had a pacer, but he won the race by like 8 seconds. So again, I think he's got some good competition this year, but there's a clear division between him and the rest of the field, at least over in the European side. And then in 6 days after Grant Fisher broke the indoor world record for the 3K, he breaks the indoor world record for the 5K, running 12:44. Took a substantial amount of time off the American record. Just, really cool to see him run 2 world records in a matter of a week. He was a guy that graduated high school at the same time, and he ran sub 4 minutes for the mile in high school. Everybody's like, hey, this guy's going to be it. And he had a great collegiate career, but just won his first Olympic medals this past year, 2 bronze medals in the 5K and the 10K. So for him to break world records is, he's kind of taking the next step. And then after that, the next day you had on the road, Jacob Kiplimo from Uganda broke the world record in the men's half marathon. His own world record.
Crushed the world record.
Yeah, by 50 seconds. 56 minutes, 42 seconds, which is 4:19 a mile. I saw the splits per 5K. Average 5K would be 13:25, but two 26:50s for 10Ks. His 5K from 10K to 15K was 12:57. It's 4:07 a mile. 12:57. And he won by over 2 minutes. And the dude's 25.
Wow.
He got started in the road racing very young, didn't really do much on the track. He has run some, but you would think, why doesn't he run? Surely he would break a world record on the track in the 10K, which I think he could. But he likes running on the road. So
what do we think's going on?
Yeah, there was a really funny satirical post put out, I think, by Grant Fisher, because he's sponsored by Nike, and in the picture after the 3K or the 5K, it was him. Are you good, Doffer? Right. Having some technical, not so technical difficulties. There's a post that he put out of post-race, and he's holding his spike, right? And all it said in the caption was, it's got to be the shoes. And which everybody's been discussing as that's the big differentiator in the last few years of these super shoes or carbon-plated, different foamed shoes. On the road, I see that playing a bigger role. They were originally designed for the marathon, and you think about if you increase efficiency in a shoe, and then you get to do that for the course of 1 to 2 hours, that's going to have a bigger effect than in a 3K, 7.5-minute race. And when we were racing in high school, there were spikes that had carbon fiber plates in them, or at least carbon fiber in the sole of the shoe. So I think he was making fun of the fact that you guys think
That's what
that
people
it
are
has
gonna
to do
say
with
it
the
is,
shoe,
yeah.
right? Like, not that all of these people are now pushing each other really, to the next level. And you think about a similar effect whenever Roger Bannister breaks 4 minutes in the mile. Nobody thought it was possible. Then after he does it, X number of people, very soon after that record, broke 4 minutes in the mile. 3 weeks ago when we saw Ethan Strand run 3:48 for the mile, 2 seconds faster than the NCAA record. In that race at Millrose Games, you had a collegian run 3:48, Gary Martin from Virginia. You had an 18-year-old from Australia, Cam Myers, run 3:47.2, taking 6 seconds off of his previous U20 world record. And like all of those guys would have been like the top 6 or 7 of the race were now the top
Any other
6 or 7 world all time. So you get in the right race with the right people, and all it takes is for everybody to be pushing each other and think that, well, he did it, so I could. There's a chance I could do it.
There's also that guy from Adams State that he ran like 7:36, and
This is Division 2.
Yeah, he was Division 2. His time would have been NCAA all-time leading for
Division
D1
1.
and D2 coming into the season, but currently he sits like sixth or seventh on the like all-time NCAA list just because you've had 6 or 7 other guys faster than him this season.
And that previous record was from 2023. So that record was set last indoor season.
Which if you also think about, we've talked about this, just being involved, somewhat in the high school cross country scene and track and field, like 4 or 5 years ago, you just like in our state, you just saw this like boom where it was like, what's going on? Like you guys were even telling me like the times that kids are running now, like you guys wouldn't have even been like in the mix with most of those guys, or, records that were broke were not even like, worthy of like top 20, when you guys were there. So like maybe that's just the matriculation now, or 4 or 5 years later, you see people coming up out of those ranks of whatever that move was. So that's what I'm always just trying to like think like, yeah, it could be a Roger Bannister moment, sure, because all of those got broke right then, but it's like, obviously people have to be better to be able to do that with the psychological push. So it's like, has something changed? The only thing that I could say that has really changed has been, I'd say maybe 2 major things. Footwear that you're training in, which David Roche talked about this quite a bit on his podcast, of which I think I was talking to you about training in a carbon-plated shoes versus not for speed work. And we looked at both sides of it, right? So if you train in them, David Roche's take is training them all the time when you're doing speed work, interval, fartlek stuff, because you're going to be able to have a higher output in an easier effort, right? So you can actually, the workload goes up even though you don't get banged up, and energy efficiency is up. Your kind of retort was, well, I want to have to work harder, both from a mechanical standpoint, right, but also an energy standpoint when I'm training. So then if I put on the shoes, then it's easier. I kind of think of it like, so when I was in high school is when like parachute training became really big for like sprinting, both being pulled, drag and being pulled. So it's kind of like, well, which one's better? Downhill running, for sprint training, things like that. Like we know all this, may have an effect. So my thought was maybe people are adapting to this footwear that they're training in, right? So the output's getting higher than they are wearing it. So it's almost like you just kind of have like a bionic human. They've gotten used to that footwear because we know it changes mechanics, because we've talked about, the stress fracture run up with the different mechanical load. So that's one thought. The other one is, I think there's a hell of a lot more cross training occurring in the running population, but also much better. So it's like there was always if you looked at, high school runners, collegiate runners, cross training was doing planks and push-ups and stuff like that. And then they ran a bunch. And now you're like, I think in particular in college, we realize like, oh, you can't do that. But also it can't be hand-me-down strength conditioning programs from other sports just to make them do something. So as you get more specific, maybe people get better there. But that doesn't probably explain people coming from other countries, and I don't know how all that stuff follows. But there's got to be something going on there that's a big shift. And besides just a mental, I think there's a mental part there for sure.
My other thing is, you weigh in both options of like, I want to work harder mechanically versus, using the shoes, and it helps your efficiency. So you work, I guess, not work less, but it's a little bit easier. To me, it's like, doesn't matter, because if you're able to run a faster pace at an easier effort, do you not just adjust the times like down a little bit? So now like effort's still higher.
So I got it. So if you ran 5:15s, now you're actually running a 5.
You're running like 5:05s, right? Repetitively. Yeah. Like, does that even matter? Like, at that point, you're still getting the same effort.
I guess if you're using RPE, is your metric.
The only thing that I see that being a difference in is just how they view other people running that time. If they see that this felt that easy and I ran 5:05s versus running 5:15s and it feeling the same effort, if they go, well, if that felt that easy at 5:05, I can race at 4:50 and be better.
Yeah, so then your whole race strategy changes based on like relative, perceived effort. Yeah. I don't know. There's a lot of stuff. So I brought that up to Travis Grappo too, because he's a huge running nerd. Huge. And he was like, bicarb. That's just the first thing he said. He's like, bicarb. That's all it is. He goes, I took it once and like best run I've ever had. I was like, yeah. So also I think like in the strength and conditioning, energy.
Yeah, they're probably drinking. Did we ever drink electrolytes in high school?
I barely drink them now.
Which there's a whole debate on that of, okay, how did people perform at a high level before we had any of that stuff?
Yeah.
Right? Because it's not like people weren't doing amazing things, and then we think we have to have all these things. But then you do think about something like, you know, a company like Morton's coming around, and I mean, it literally does change, you know, pH balances and your ability to shuttle things. Like it. So there's that. Now, we'd have to look at how many of those athletes are actually using that stuff, and I doubt it's actually that many. I don't know. It'd be interesting.
A lot of them are using that other drink, the ketone IQ.
Yeah, which that, again, we get into the mental, the big one there besides recovery, because they've found most of the research looks at the recovery from an endurance standpoint is coming at taking it after, right? And your ability to basically not have to utilize glycogen and glucose for like brain, right? Because that's 20% of that. And taking it after, you're able to shuttle, you know, things into the periphery. And then I'd say for longer bouts, which maybe the half marathon gets into that, but it's a lot of that central governor theory of like, it's easier because you have that, which maybe if you pop it before 5K and you're all, you know, lit up or neurologically stimulated, I don't know, maybe it is easier. I don't know. I wanted to get some of those for this race I'm doing this weekend, but I haven't. Maybe I will. Probably crap my pants or something if I've never taken them before.
It's also expensive too.
Yeah, it's
in my opinion.
Come down a lot though. So I was looking at it's like $20 a shot, isn't it?
No, that's for the like big bottle. I think it's like $4 or $5 a shot.
Oh, okay. It used to be $125 a shot. So you used to come in 3 vials when they first came out. 3 vials that were the little like immune booster size shot things, and it was $125 for those 3, or not for a shot, for those 3.
Yeah.
Yeah. So it's come down, but we'll keep. I mean, obviously Alex has been putting out posts every Thursday. It's a lot of track and field stuff, so follow along on that. But I mean, we're always, you know, we're talking with runners constantly in here because people in the amateur ranks of running want to lean on nutrition and shoes and stuff harder than they should, because that allows them to put in the same effort and expect something better. But at the end of the day, it's still effort based in terms of training. So I shouldn't expect much difference in this 50K after falling off after 8 weeks. But the last time we've also put in a dedicated 8 weeks of training is probably when you and I were training for a 5K. So yeah, it still should be better than it would have been if I was just doing nothing. Let's kind of jump over to just interesting cases. So if you guys have any, just fall in at any point. Like I said, we used to do a very deep clinical dive on like 1 or 2 cases, and that was fun for us and our, you know, crony friends. But I think we all get a little bit more out of it if we just kind of highlight some interesting stuff in here, things that were different. And again, if you have any questions about this, you can always, you know, post in the comments of this video or send me an email. But one of them was a woman came in, she's in her early 60s and was having bilateral shoulder pain, and she does private training at a local gym here, and basically just said, I can't do anything. My right shoulder's worse than my left, but I can't do anything because my shoulders are killing me, and then my right shoulder in particular is killing me at night. So in our clinic, and anybody's clinic that, you know, knows their head from their ass, both shoulders are hurting you. We're like, oh, it's probably not your shoulders. Maybe there's something going on with the right shoulder, but then it's still got to be something central if it's both. And that doesn't mean necessarily like you have a neck issue. It could be how you're operating around your, you know, around your rib cage and your scapulothoracic joints. So with her, at first she was like, well, I'm not really doing anything with my shoulders because it was just bothering me so much. I was like, okay, let's just not do that for a week. So we take her through some tests, and like we can recreate neck pain on her right side. So that's kind of positive for an orthopedic test. But like she has almost 0 rotation through her thoracic spine. I mean, she's a little bit kyphos, and then she literally is telling me that her low back hurts if she just walks for a long time. So she's just stuck in extension because she's flexing her mid back. But like every visit with her, I've had to talk her back into the fact that it's her mid back, even though her shoulders aren't bothering her because she's not doing anything. Which I try to tell her, like, if you can do stuff in your day to day and it's not bothering you, besides when you went in there and like did presses and lateral raises, that should tell you don't have a shoulder injury because you can do day to day stuff. So I'm just want to throw that case out there because I'm sure a lot of people, maybe not a lot of people, have, you know, both shoulders bugging them. But if your shoulder or whatever is only bothering you during a hard challenge, you go in and bench press and you're like, my shoulder bugs me then, but it doesn't bother me any other time, you probably don't have an injury. It's probably either how you're bench pressing, it's how you have to move around your shoulder when you're bench pressing because of how something else doesn't work or doesn't, you know, integrate or sync up. So I want to highlight these cases for almost patient, not just education, but so like you kind of arm yourself if you're working with somebody or, you know, you're Googling stuff that you're like, that doesn't really make sense. If you, again, trying to logically break down, like, why would both my shoulders hurt? Why would they only hurt when I do this? Instead of just Googling, shoulder pain, you're going to get rotator cuff tear, labrum tear, and then you're just down this pathology rabbit hole. So I wanted to highlight that one from just a pure functional case. I have no clue if she's actually better because we can't reproduce any pain in her shoulders on an orthopedic test. They move fine. She's very mobile. We can recreate neck pain. And I sent her home with retractions, and her neck got worse. And I was like, perfect. Like, you have a neck problem, obviously. That doesn't mean that's like going to solve all of her shoulder woes, because there's probably a big like how you do things around your mid back once we even get your mid back moving. But it's just solely get your mid back moving and kind of see how things go. Another shoulder case. So this guy has had bilateral shoulder problems, but he had a left shoulder problem a long time ago. Now he came in with a right shoulder problem. This guy, so he used to come in with a little piece of paper, and it would tell me all of his warm-up drills, all of his exercises, and he'd just go over every visit, even though it hadn't changed since the last visit. And then he'd get done, he goes, what do you think about that? And I kind of got to the point, I was like, yeah, it's good. Because I just, whatever I said, it's not going to change. Now it changes because we've had success. But this guy wanted to see how many times he could do 185 barbell bench press, and his right shoulder started bothering him. We had told him with his other shoulder, which he had a legitimate labrum tear diagnosed on MRI, and we said it was non-surgical, and we got him over that without surgery. So that's where the success came in. And he came in, he's like, got the same thing on this shoulder. Started hurting bench press. I was like, well, let's check it out. It was not the same thing. I think he has probably grade 2, whatever you want to call it, tendinopathy strain of his supraspinatus. Very specific testing that shows that hurts with, putting a shirt on in the arcs that we would expect, like the first 15 degrees, and then up top, and then coming down, he gets that big catch. So I want to bring this one up because when I tested his shoulder the very first day, he would have pain with some of our classic orthopedic tests, right? So like your arm at 90 degrees, external rotation 0, empty can, which is supraspinatus test, kind of moving from that labral shear test from the pronator position to the supinator position, that caused pain. Pushing hurt, but he was like, that was worse. But he had no loss of strength. Like functionally, it's like clean, but like he has pain with almost everything with his shoulder. So we've taught, obviously you guys know this, we talk a lot about what the orthopedic test is doing. It's testing integrity of a tendon, a ligament, the labrum, whatever we want to say. So I explained that to him, and I'm glad I did, because he came in the second time and he's like, I just don't think I'm doing any better. We test everything. He has less of those tests are painful, right? So it came down to just empty can. None of the pain with going from pronation to supination, but he's saying it's the same. I'm like, no, it's not. Like, it's functionally improving. I know your pain's the same, so I think we should keep going. Because he's kind of worried, do I need an MRI? And also, no. Comes in the third time, and he's like, God, I had, some good days, but I had some days where it was worse. I what you want you to do? He goes, well, I tried dumbbell bench press and started with 20s and then 25s and 35s and got to 45s, and he's like, I couldn't do it. Yeah. I was like, how many sets today? He's like, 5 sets. I was like, so you did something you haven't done. Mm-hmm. You did the thing that hurt it before. Mm-hmm. And we go in and test him, and nothing hurts, right? So, and he's like, yeah, but he goes, if I put him a shirt, I'll get a catch. So then you try to explain, okay, functionally your shoulder's doing better, but now your strategies around how you did stuff, and literally if he just thought about not elevating his shoulder while he did this stuff, is way better. So if you think of your supraspinatus, I always explain to people, it's a little muscle and tendon that's going to live right under your AC joint, and it's like a butter knife on a rope. If you get into this elevated position, that's basically a secondary shoulder impingement. And I was like, I'm not saying you got to do that all the time, but watch how it changes when you're just cognizant about your shoulders working. Another good point for people to think about of how do I determine the difference between what an image says, what I Google, and am I actually having progression if I'm at a PT, a chiro, or just trying to get over something myself? Because now we're always telling people to test stuff. Hey, now you go try a dip, right? I told him, hey, I don't want you to try to just dumbbell bench press again. I'd like you to try to do a push-up beyond, on a parallel or a box or something, and see if you can get into shoulder extension without your shoulder just going to this elevated position. Because he tried one, and he's like, oh, that hurts, but his shoulder was up in his ear. And I go, can you try to just think about that? And he did. He's like, oh, it doesn't hurt. I was like, again, maybe that's not what we do, but we can use that as a test, right? So if you just drop yourself into that movement a couple times before you go do your workout, because he's going to keep doing this stuff, and your shoulder hurts, maybe you shouldn't do those other things. So it's a preemptive test, but then knowing him, he'll probably start doing push-ups from parallettes, and that's fine. Yeah. Because I explained to him, hey, it's a closed chain movement. It's a little easier to work around and stuff like that. So, thought it was interesting.
That's actually, we had Peggy at the gym. She's either the post coming out today or it's coming out this week about one of the gym goers who she would do a single arm row, and she said she had upper trap, shoulder pain doing the single arm row, and Peggy videoed her doing the row. And you see the first rep where Peggy says, okay, I want you to row this weight and pull the weight to your back pocket. She does that, no shoulder elevation. Then she doesn't tell her anything on the second rep. She immediately goes to shoulder elevation. You see her upper trap pull, and she goes, oh, yeah, that hurt my shoulder. It sounds like the exact same thing.
So it's, and, I don't think I did a post about it. I should do a video on, like, motor learning and coaching, like, the best way. So if we get somebody that has like a bad rep, a painful rep, we don't highlight the bad rep and be like, see, you elevated your shoulder, because the whole reason somebody does that is because that was a good way to operate. It got them out of pain. It allowed them to move their shoulder into a position they couldn't. So now to highlight the bad and say, well, don't do that, they may not even be aware of how to do the other strategy. Hence, when she didn't have any coaching, she just went to a position that created pain, which seems not logical. Like, why would you create pain? Right? You'd be like, you'd think she'd do it the non-painful way repeatedly if we just showed her how to do that. But like, your brain gets set in a pattern, and there's no reason to like dig itself out of that rut. So that is literally like a motor learning strategy that, keeps you in a pain pattern without maybe an injury. So that's, again, I tell people all the time, it's the reason we have a job. We're trying to not just say, oh, that's a bad rep, let's do it this way, and then try to be like, why is that so hard for them to do? Or why can't they conceptualize that? Or what can't they feel? Or whatever. Maybe they can't move around something. Maybe their mid-back's stiff. So it's hard to, retract and depress their shoulder blade. I don't know, but that's our job, is to figure out, is there a why? Maybe it's not. Maybe it's just coaching, right? It's technique. Okay, then we can coach them, but it's not just, that was a bad rep, let's keep our shoulders back, and then pretty soon they're like, well, I'm having pain even doing that, and you're like, well, I should have assessed stuff a little more.
That was a part of the discussion for her, at least, when she was asking, what could I do to tell her that, or how would I word something on the caption about that? So instead of saying that the shoulder elevating was a bad rep, say that the other one might be more efficient.
Yeah.
Because your upper trap is going to elevate your upper trap's doing what it should. It elevates your shoulder blade. But if you're trying to pull a weight to by your side, your shoulder blade shouldn't have to go up. That's counterproductive for where you're bringing the weight. And if the lat's going to extend the shoulder blade or extend your shoulder, then that would be what you want to use more so in that position. So.
And again, trying to like weaponize people with logic, like, again, why would you do this if it's not the best way to pull weight? That's a question that, you could ask, but that gets hard. That's why having somebody look at you and be like, God, you really, or maybe your shoulder can't extend.
Yeah,
so
she
you
may
go
not have
up,
the option.
and that is literally our first job, is like, can you do the movement, or are you choosing not to do the movement, subconsciously? And then you can make a dividing point of like, oh, that's a complete Coach Peggy job. Like, she needs to coach you up on this, get you to, pick that pattern up, eventually make that a subconscious motor pattern. Or, dude, we got to work on your shoulder, or you do, and get it moving different. And then this gets a whole lot easier, and there might not even need to be a reason to coach it. So I wish more people understood that, because there's just a gaping hole of, well, if I think about it like this, it doesn't hurt. And then they wonder why they have to consistently think about that all the time. And you're just not hitting that, like, putting the cart before the horse type deal. This one's just a little bit different. It's just one of those that you're like, whatever. Somebody I've seen forever, and I was seeing her she was basically having pain just inside her shoulder blade. Her right shoulder is just chronically elevated. I'm talking like literally you cannot pull it down. She's hanging off all this stuff, mainly through like brachial plexus tension. I saw her like 4 or 5 times, and it really wasn't changing. She was having radiating pain down her arm, and we'd get that to go away, come back like 2 or 3 days after a visit. Well, I didn't know. She just went to a PT that's like really close to her house, and she came in. I hadn't seen her for a month. She came in and she goes, well, that was my first rib. And I was like, oh, okay. And Beau 10 years ago would have been like, no. But I was like, oh, okay. And she goes, yeah, so the PT just, I saw him twice a week for like 4 weeks. And I go, well, how is it? She goes, well, I don't have anything down my arm. I mean, it's still like pretty bad, like up in here. I was like, so what they have you doing? And she goes, well, some flossing. Well, she didn't say flossing. She goes, this, right? So I'm showing you like a median nerve flossing thing. And then she was like, yeah, they just pushed on my, around my pec and kind of did a lot of soft tissue. So I was like, okay, but it's better. So whatever, in her terms. I just point that out to not say like, oh, I was right, they're wrong, what we're going to do is different. It's just the confidence with which you say something. Again, that person was like, yeah, it's first rib. And she's like, oh. Whereas I was like, yeah, I think it's your, brachial plexus has a lot. Like she doesn't know clue what I'm saying. But like, she even said that she went home and Googled her first rib, and like saw a picture of it. So now she has an image of it in her head. Yeah. So I should have done a better job with her, because I've seen her for so long. I just kind of figured like, well, she's not going to just go off to PT land and do some weird stuff. So the interesting thing with her is from the clinical side, her first rib moves awesome, right? So from a joint standpoint, but in our world, if somebody has like brachial plexus tension, if we take them through a flossing maneuver, we'd be like, oh, that's kind of a no-go for right now. We got to like detension it. And that's what I was trying to do with her with like some DNS and exercise the whole time. So it's kind of interesting that she's like, yeah, if you do this, which is probably the soft tissue that they were doing, just getting stuff moving because it's a giant like brachial plexus nerve entrapment around there. But it still goes back to strategy. Like, why is this? I mean, she literally lives like this. So if she walked in, you just be like, why'd she do that? Tough one. But then at the end of our visit, she has like a 20-gallon purse and she just throws it on that shoulder and she's hanging out like that. I go, can you just not do that? I go, I hate to be that person, but just don't do that. She goes, it's so hard. I go, you're literally doing this to hold that purse up. She goes, I know. So again, I'm not saying that causes it, but it doesn't help anything. So, but I bring that one up of confidence of delivering, for a patient and a clinician. If you deliver something confidently, it doesn't mean you're right? That you just get buy-in, but a patient, realize just because somebody delivers something confidently does not mean that they're right. You got to play both sides of that. Interesting one from my standpoint on the clinician side, a person that, a good friend of ours, we all ran a half marathon a couple weekends ago. During the half marathon, her left knee started killing her, in particular on the downhills, to the point where she's probably the fastest woman in our group, and she came in close to the last woman because it was bothering her so bad. But post-race, she could flex it fully, do a squat, all this stuff wasn't bothering her. She goes, it just seemed like it was impact, and she's had a history of low back stuff. So she came in the other day, she's like, my knee's still bothering me, and she goes, they went to the Daytona 500, and she goes, on to the way to Daytona, they drove, she goes, my whole leg was just like going numb and tingling all the way down to the basically medial arch of my foot. I go, okay. She goes, that's better, and it's just kind of like above my knee, like in my hamstring now. I go, okay, let's check it out. Positive slump test on that side, both for, I guess you'd say positive aberrant neurodynamic test. So like lack of range motion or ankle compared to the left, but then also like straight leg raise is positive. Slump just by itself with no like neurodynamic, not really positive. But then her quad had a bunch of trigger points in vastus lateralis and, through rectus and just like twitchies all get out. And I go, okay, so your back's not bothering you at all. You got this kind of ridiculous stuff. Your knee is the big complaint. Let's just treat your low back and the nerve and just kind of see what happens to the quad, because I think that's causing the knee stuff. All those trigger points went away and we didn't even touch her quad. So I point that out again for us because we're always talking about an audit. So that is a perfect functional audit of a trigger point. It isn't even technically, it's kind of, obviously it's lumbosacral plexus, so obviously all those nerves converge at some point. But if somebody came in, sometimes we just think, oh, it's sciatic nerve, and then your quad, and for some reason we like splice those out. Well, it can't be that. Yeah. Which is your low back. I mean, L2, 3, L4, like if your back is getting compressed, it's not for whatever reason. And we didn't do that much work on her low back. It was like getting her sciatic nerve moving, soft tissue, some openers on that side, and I mean, gone in terms of trigger point. Now, will they come back? If she goes and runs, will it come? I don't know. Pointing that out again we know a lot of lower extremity pain is derived from your low back, and that doesn't always mean like neurologic radicular stuff, right? Mm-hmm. Those muscles might be getting more neurologic output because your back is kind of angry and you have signals coming in and out, and it's kind of just like everything gets a little chaotic and you just bombard muscles based on you are doing work. You're running downhill and now that muscle's just like has to turn on all the way because it doesn't have like a good throttle. So it's like 0 or 100, and that's kind of what a trigger point is. Again, I'll have a follow-up next time on her for sure and just kind of say like, yeah, like working on her back is kind of the thing that helped her knee the most, or maybe it didn't, but no positive orthopedic test on her knee, no swelling, no point tenderness on her knee. So you got to be like, okay, there's something else going on here. So thought that was interesting for sure. I'll skip this one because we're running out of time, but one more guy that I've seen forever came in the other day and he switched careers completely, and he's in his 50s, moved to building homes, and he said he was flipping over a countertop, like a Formica countertop, and felt a pop in his elbow and had extreme pain, but he's like, I kept working, and he goes, about 3 hours later, he goes, I literally couldn't like pick up a hammer with my left arm. No swelling or anything that day, but he goes, like the next day when I woke up, he's like, I couldn't like move my arm. No bruising, no anything like that. So he comes in and he has a brace on that elbow, like a Velcro brace that he's been taking, ibuprofen, still been working, but there's things he can't do, and takes off that brace, and a giant pocket of swelling on the inside of his like distal bicep, and just kind of look at it, test it. He has pain with all ranges of motion that are resisted, right? So like 45, 90, 135 elbow flexion. but he isn't giving up ground on any of that. I bring this up because I just put out that video on, is it a nerve injury or is it a strain, and like how easy it can be to diagnose a strain. If somebody has swelling, you had some sort of soft tissue injury, like that amount of swelling. I mean, it's pretty diffuse. It's in a focal pocket. He's not able to do things. It got really bad a couple hours later, right? So obviously strain, not rupture. Also didn't have recoil. But he's in an age category where being very sure that like what grade that strain is, because this guy could get out of pain in 2 weeks. He goes and flips another countertop and just absolutely ruptures a bicep off the tendon and, has like the necktie roll up off a cartoon into his shoulder. So he's very like, what can I do? What should I do? Because he's like a small crew because he's just doing this, home building on his own. But I bring that up about the diagnosis thing, right? Because was it a tendon? Is it a muscle strain? Where is it at? What grade is it? So with him, based on how it tested, like you can almost unequivocally say like musculotendinous junction, like a 1+ strain of the long head of your biceps. Why that matters? I mean, now your rehab is super specific to, okay, it's about a week old. He did say that it was getting better, and then he touched a hot wire and yanked his arm back, and he goes, that sent me through the roof. So fast twitch stuff with a muscle strain is going to drive it crazy, just like if you come back after a hamstring strain and everything's good, and then you take off to sprint, you're like, oh, gets you again. So I had to like paint a picture of him of like, okay, I'm going to give it 3 visits, and if we don't see, really good progress, or if it goes backwards, you do something at work, you catch something, we might get an MRI just to protect this guy so he doesn't. I mean, if he's building homes, that's his livelihood now, and he ruptures a bicep, he's out for like, minimum 8 weeks, if not longer. So the guy wouldn't be able to work. He also doesn't have disability insurance because it's a small business that he just started. So taking all of that in is a good management piece of like, well, I'm not just going to fly off the rail and be like, I think it's a mild strain. Let's just kind of start loading it. Like very specific on the angles. So we're playing in that 135 because long head. Pronation versus supination matters because of where he actually feels the most kind of tenderness when he's loading it, right? Because you're going to change how much of like brachioradialis and short head versus long head, using dry needling to create a pro-inflammatory things. It's week old. So all that comes into play, which it could be wildly different if he comes in the day of. I'm not sticking needles in the thing. I'm probably not loading it day of. If it's a, grade 1+ strain, I'm going to keep it moving, get the edema out of there. So again, being diagnostically accurate for a clinician, top notch, but for a patient, you deserve that amount of accuracy. So your treatment is very specific. So you, don't get knocked out of work, but also I could have this guy doing things pain-free in 2 weeks. But then I told him right then and there, I was like, you're going to have to be cognizant of not just flipping a countertop over when you're out of pain because it is a strain. And that's hard if you're out of, say we make a mistake and he has no swelling. We're like, oh, I think it's just a nerve or something. And he flips a countertop in 2 weeks because he's out of pain and ruptures this. I mean, that's on you, So again, the swelling helped. There were certain things that kind of pointed that out, but yeah.
Did you ever think, because he didn't have any weakness, right, when you were doing any of the...
He wasn't buckling. I mean, he said that, and again, you take their history into account. He was like, I couldn't lift stuff. But then he had also told me over the week it had gotten better. So that's where I'm like, grade 1+.
Yeah.
Right? Also, he didn't know any swelling. So if I have a tendon that you keep using because he's doing construction, it's going to get pissed off. So that's why I was like, okay, that also sounds like a mild strain that you're just not able to let it heal because you got to do stuff. So yeah, I mean, so in the treatment, we dry needled it for a pro-inflammatory cascade. I taped it up to try to draw the edema out of there, back up towards his, axilla. Went through isometric loading, and I said, hey, we're just going to do 2 to 3 days of isometric and then probably move into like eccentric stuff because I think we need to because it's grade 1. But I need you to go home and make sure it responds well and also see which angle is kind of the worst, but in a good way. Like, where do you feel it the most, where by the end of those 4 to 5 sets, you're like, oh, that's achy, and it was that 135 because we did 1 round of it in here. Next time, because it'll be a little further outside of the acute window, we'll do some BFR and, maybe go through eccentric loading with that stuff and just push him a little bit harder. So, like I said, I think in 4 visits I can get that guy like going, and then he's going to have to continually load it, for the next couple weeks specifically. But I said, you could use stuff at work. You can go up to countertop and just do an isometric for 45 seconds. It doesn't have to be a band or a rope or, it could be a saw or something. So we can make stuff up, but yeah.
When you were deciding whether it was a strain or not in the first, what was telling you that the swelling was coming from musculotendinous junction versus it being neurogenic.
So again, where your pain is, when we test him up here, he has no pain at all, right? So the lever, so you just work your way down, just like when you do, so if we have a hamstring strain, right? Somebody's on their stomach. Yeah. You're going to start them at, maybe less than 90, so maybe 45, depending on their range of motion, but 90, 135, 160. And you're thinking you're working your way down the hamstring, but also like the further you get out with some people, the higher they'll present with pain up towards their ischial tube because the lever's at its longest. And you're just, in my opinion, you're working further out from the muscle belly. So if everybody listening or watching, if you just take your bicep and squeeze it as hard as you possibly can in a ball, you're going to literally probably almost cramp like in your bicep. Right. But if I had you hold something for the longest time in a straight arm, you're probably going to feel strain, like for most people down in your elbow, right? Just because we're not doing a lever with our shoulder. The other thing was when I tested them, so we found out that, and I'm saying a big arc of flexion, right? So maybe this is 150 degrees. I don't know. The higher I got him, the better it got.
So the more he uses shoulder.
Right. So the more he's up here, right, offloading this, like he's like, yeah, I don't really have anything. So I was like, okay, that seems like it's deep in there. I don't think it's on his bone, right, just because of how it's acting and things like that. He's also 50, so it becomes less likely with that injury. He felt a pop. What's that mean? Maybe something. But that's also the most susceptible area of a muscle if we don't think it's a tendon injury. And the way it's acting doesn't sound very tendony that it got better in a week. Right? If he's like, dude, I can't do anything. And I mean, you might pull the trigger on an MRI even if somebody's coming in there in that full range motion, mild pain, they're not buckling, but you're like, say it's blown up like a balloon and, stuff like that. But yeah, so that would be my strong assumption. Right. So that also tells me where I'm needling. But that's also when I'm palpating, right? I palpate on like head of the radius and stuff like that. Like there's nothing, you move up and you're like, it's kind of in that, junction. And how big that junction is a little bit different on everybody. But yeah, kind of a little bit of that. Let's move on while we still got 10 minutes or so to some research articles. Did you guys get a chance to look at these at all?
No.
These are just interesting. We're not going to like get in the weeds. We'll put links to these in the show notes here. One that I thought was interesting, this came out in, just 2 weeks ago, a week ago? It just says February. Published in September, released in this journal in February. Okay. It says uphill treadmill running and joint mobilization improve dynamic stability and ankle dorsiflexion and range of motion in young adults with chronic ankle instability of randomized controlled trials. So Lane Norton would be happy. I just thought it was interesting because they're literally using, it was either a standalone running group, so you're running on a treadmill uphill for, this is 3 times a week for 4 weeks, 20-minute running sessions, let me read through it. So participants were randomly assigned to 4 groups, combined uphill running and joint mobilization. The joint mobilization was like grade 4, so it's just joint mobs. Uphill running alone, joint mobilization alone, and a control group, so people that had restrictions that they did nothing with. The uphill running with the joint mobilization and the uphill running groups is 20-minute running sessions 3 times a week for 4 weeks. And then they used a Y balance test because they're trying to look at chronic ankle instability. The Cumberland ankle instability tool, which is I don't think that awesome. And then weight bearing lunge test. So that's, not too far off like a Gary Gray type thing. Not non-weight bearing ankle dorsiflexion degree using goniometer. Reading through this, the biggest group that showed response, which again, the most input was the people that are getting joint mobilizations and running uphill. But when you read through kind of the methods and the outcomes here, because it says the uphill running and joint mobilization was superior to either intervention alone with a success rate of 1.55 times greater than just uphill running. But when you look at the uphill running versus with the joint mobilization, like they're kind of the same. So I was just talking to Seth about it. It's not confusing. I understand why, but like I run a lot of trails and there's always a lot of hills, but there's also not maybe 20 minutes of a hill, right? At the same incline in a controlled scenario. But I know a lot of people that do a lot of like long, slow hiking, running where they are doing either hill repeats or they be doing enough. They're going slow enough. Like they're putting in more time than that. And I don't want to say I guarantee you, their ankle mobility is not improving and the chronic ankle instability tests are not improving in those people. So I just thought it was interesting that, what is the mechanism there? Again, we know that joint mobilization from like a grade 4 or grade 3 if somebody's doing it for you, you're doing it on your own. Like, yeah, you're going to improve a little bit of input, but like, how much is that actually going to change if you have a joint restriction or tissue? I don't think a whole lot, right? It gives you more feedback. So the ankle instability stuff makes sense. The Y balance test and stuff like that. The dorsiflexion, that was an interesting thing to me. That's where you saw it was almost the same, whether you got joint mobs or running. So then it's the uphill running that's the factor, right? Because the joint mobs are helping the stability test. So one of the harder things, in my opinion, to change is ankle dorsiflexion, right? You did a undergrad research study on breathing and ankle dorsiflexion because we were just curious. We're constantly leading ourselves back to an ankle that's like probably causing a lot of this, but also that's a long road to walk, or will it change at all? Or should we focus on it because it's hard to change? So it would really be a smack in the face if it was like, oh, I should just have everybody either walking or running on a treadmill 20 minutes 3 times a week, and that would actually improve their ankle mobility better than anything. So I just wanted to point this out in terms of like, I don't know. You'd have to understand the mechanisms better. Also, if you looked at the amount of load that is, so 60 minutes, total, that's not a ton, right? But if we looked at like Keith Barr's work for like a tendon, what I was kind of looking at is, right, so after about, 2 to 5 minutes, that tendon stops kind of, having a recoil. So now you're going past that point. If I keep working it, maybe if you had a stiff area of a tendon, just like he says, you have to load the tendon enough to allow the portion that won't load to evacuate fluid, but also get tensilely, loaded. Maybe that's what's happening, is you lose that recoilability of the tendon. And then as you keep walking uphill, you're like maybe pulling on that portion that's not stretching, or fascia, or whatever we're going to say. Because again, this isn't people that have Achilles tendonitis, but if I had to guess why a lot of people have stiff ankles, you've had massive adaptation around the end of your gastroc soleus group, and that's what's stopping you. So I think about one of our patients, a young guy that used to play tennis and now trail runs, that has less than 0 degrees of dorsiflexion. Like, he's in the negatives by maybe 4 degrees. What would happen if I gave this to him? Because I've told him forever that, like, you have to change this because that's a cause of some of your back pain, and he had a hip surgery, and then he has knee problems. So I'd just be curious, and he would be probably somebody that would do it, right? But it would be out on a hill on a trail. So yeah, it's just kind of interesting to think about with those people that you're like, I need them to change it. Maybe you're like, have them do this. I don't know. What do you guys think?
I think it would suck.
It would
20 minutes 3 times a
running.
week.
And the grade was 5%.
That's no joke.
Yeah, dude, that's not
Let me make sure on that grade.
Dude, those are some fierce runners.
Yeah, 20 minutes straight hill at 5%. You're probably talking
280 for a heart rate.
That's David Roche Leadville training right there on his.
I'd be at max heart rate for at least 17 of those minutes.
It's probably a 2 mile plus hill.
Oh yeah, you'd be grinding. I could see why something changed. You literally had to.
I'll put in the show notes the grade, or I'll put the whole article in there. It's downloading right now, so I don't want to take the time. The other article that I thought was kind of interesting, just because I've been going on a little more deep dive into fascia land, which every once in a while just kind of pops up with, interesting stuff, and people want to blame all our woes on it, or that you can fix everything by the focus. Not gout. I was going to talk about gout. That was another thing with that patient with the elbow problem. But was an article that came out August of last year called Fascia as a Regulatory System in Health and Disease. So again, the article is almost looking at it as like the end all be all. But what was interesting, or I thought was interesting, is this concept, and they literally call it the Watchman, of the ability of fascia to communicate. And we knew that fascia could communicate, or was communicating faster than neuronal communication, right? So like, as fast as your neuron can fire, which is different for, a C fiber versus like an A fiber and things like that. But like how fast those can communicate, somehow things were happening faster than that. So then it came down to basically testing both the electrical gradient and piezoelectric gradient of fascia. And they kind of found out like, ooh, fascia is communicating this. Still, people don't understand how. That's why even some people are thinking there's some sort of quantum entanglement with fascia, which gets wild. But this is also saying now they think like, immune regulation is coming from fascia communication. So if we thought about like where lymphatics live, you kind of like start to, I guess, like use logic to be like, yeah, it can make sense. I bring that up because this made me think of somebody like Kelly Starrett or Perry Nicholson. So one of Perry Nicholas's biggest things is like, lymphatic mojo, which I took that class. It's pretty interesting. And then, if you're getting like a lymphatic massage, like he even said in that class, like it's the pressure usually of like a nickel on your skin. Like it's nothing. Then you think about Tim Brown. If anybody knows who Tim Brown is, he's been the sports medicine director of the World Surf League for like 20 years. He has recently kind of coined his own method called SPRT soft tissue. So SPRT was specific positional relocation taping. So he's like the godfather of like kinesio tape. But he does these like super light strokes over an area, which he says is based on Wilson's law, right? So whatever nerves innervate a joint, innervate the surrounding musculature, right? I think that's Wilson's law.
That's a long way back.
So he's saying that if you gently work on the periphery, that you'll like joint restrictions and things get better, right? I just bring this up because it's a good thought piece. So if you're a clinician listening, you need to read stuff like this. And this gets back into the art of assessment course of having this good base of your pyramid of core sciences, a good filter to be able to read stuff like this, look at somebody like Perry Nicholson or Kelly Surratt. Kelly Surratt's huge in, lymphatics, getting fluid out, flushing it both for the proprioceptive, mechanoreceptive response once you have that fluid out of there, but also just like healing rates go through the roof. Tim Brown. I mean, before it changed to the movement advocate, like, Steve Capobianco was the fascia doc, like all these things kind of tie in. And again, I don't think it's end all be all, but like trying to conceptualize the way that you treat things and not just going in, with a hammer and like, from the treatment standpoint of bypassing these things. And I think that's where you can appreciate like, well, different tissues and different nerves and different structures respond to different amounts of pressure and different amounts of load, like the running study. So always thinking about not just like I'm working on joint stuff, right? Why would the joint be restricted? Why does this guy still have swelling a week later? But the more you think about this stuff, the better clinician you're going to be instead of just being like, I'm going to get swelling out and Kelly Surratt says wrap it in a voodoo floss band and move it and I'm pushing fluid out. That doesn't really help you to just do what somebody else says, even though it might work. You got to be like, why does that work? Why doesn't it work on some people and it does work on other people? So again, read this article if you get a chance. Just interesting. Obviously, there's a ton of research on fascia coming out all the time, but I have a whole folder on that. But I'll be doing a video on the myofascial meridian crossover with acupuncture here pretty soon because I didn't realize, it was something I didn't know, that quite a while ago, blanking on the researcher's name, they took Travell and Simon's work and overlaid that with acupuncture meridians, and they redid the study because it was originally like a 75% overlap. They redid it, and it's like an 81.5% overlap in myofascial trigger points and the referral points and then acupuncture meridians. So again, why does that matter? Because I'm big on learning referrals and things like that. So then if you're like, well, a lot of these acupuncture points are trigger points, and then just like our motor index points guy, you're like, if I treat in a chain, I have a bigger effect on a trigger point. Like, again, you're trying to hone your skills. So you're like, I don't just stick a needle in a tight muscle. You're trying to be better than that and just, play around too. So you can get creative, be like, I'm going to do every, acupuncture points 3 points away from this trigger point. And then the coinciding trigger points. So a lot of your acupuncture points are trigger points, right? And then you think acupuncture points are holes, right? Or vacancies. So then you'd be like, well, what is that? Well, that's where fascia is going to intersect. So those are the envelopes. So I don't know. It's something to think about. And like I said, I'm digging through some research. I'll do a video, just kind of my thoughts. I know a lot of people talk about this, but yeah, that's what I'm interested in right now. Any comments on the Watchman of the fascia? None. So go look up if you haven't. Tim Brown, SPRT therapy. He's doing live Instagram stuff like once a month. You can get an invite to that. We'll put links to these articles. If you have any questions, whether you're a patient or a doc about anything we talked about or anything in the future, let us know. And we had such a massive live chat. It'll be impossible to get to all these questions over here. So we'll do our best. And I guess we'll see y'all next time, right?
Yep.